Hi everyone, I'm Louise, a dietitian and a diabetes educator from Thrive Nutrition and Fitness, and this is a series on type 1 diabetes, more of an introductory course for those who've just been diagnosed or want a bit of a recap to start from the foundations of the condition. This video is going to be the basics of treatment for type 1 diabetes. From watching the first video on the pathophysiology of type 1 diabetes, we now know that people living with type 1 diabetes cannot make their own insulin and need to get it externally. Now, insulin is a protein that is broken down in the stomach if ingested, and so it needs to be sent straight to the blood via an injection. So we cannot escape the injection, and people with type 1 diabetes probably need to inject themselves every day, actually multiple times a day, for the rest of their lives until there is a cure or some other form of treatment. One of the major roles of the pancreas is to watch the blood to see what the blood glucose is doing. So when there is a lot of blood glucose, the pancreas produces more insulin. When the levels drop, it produces less insulin to help keep the body in balance. Now, without that function, we need to take over, and we have blood glucose monitors for this. Now, there are continuous blood glucose monitors that we can stick onto the arm or another area of the body that monitors the blood glucose continuously. But if you don't have one of those, it's the finger prick, sticking it into the glucometer, or sticking a bit of blood into a strip that goes into the glucometer to tell you what the blood sugar is. It's really, really important to know what the blood sugar is, because that will then help you decide how much insulin to give. Because if you give too much insulin, there is a problem. If you give too little insulin, there is a problem. We're aiming to keep the blood glucose in a certain range, and too much insulin will push it too low, and too little insulin will allow it to rise too high, neither of which we actually want to happen. The important thing to remember about insulin is that it comes in different types, and we can give ourselves different amounts. So these are the two things about insulin that we must be aware of. The types of insulin include long-acting insulin. These are your basal doses. So we give ourselves one injection of this perhaps at night, and it just drips little bits of insulin into the bloodstream over a longer period of time. It's about 24 to 48 hours, just to keep a basic level there. And the amount of basal or long-acting insulin that you give yourself at night is determined by your healthcare professional. Another type of insulin is rapid-acting insulin. Rapid meaning very quick. So this enters the bloodstream and starts working after about 15 to 20 minutes. It peaks quite quickly and then drops and becomes inactive after 2 to 4 hours. And this insulin we use as a bolus dose. Bolus meaning to cover a meal, to cover the carbohydrates that we eat at a meal time. If we combine these two insulins, we can create a mixed dose, which might peak and take a little bit longer to wear off to cover a meal and a snack perhaps. Now, the way that you use these different types of insulin and the different amounts of each insulin is called an insulin regime. This is how you combine your eating with your injecting, with your testing, to create a structure almost of treatment that is best for you. There is no one size fits all. We all have different regimes. We just see what works best in each individual case. What I'm going to talk about today is called the basal bolus regime, which is probably the most common when first diagnosed. Basal meaning we get that long-acting insulin, and bolus meaning we get the rapid-acting insulin to cover carbohydrates at meal times. With the basal bolus regimes, there are two ratios that we need to remember, keep at the back of our heads to help us calculate how much insulin we give at a meal time. So basically, insulin covers carbohydrates. So for example, if I eat a slice of bread, I might need a unit of insulin. If I want to eat 10 slices of bread, I cannot expect that 1 unit of insulin to be enough to cover all of that. So the reason we use ratios is so that we can have a little bit of freedom with our eating. So if you want to eat a little bit more, you can just inject a little bit more and you're covered. Okay, so that is what we are aiming for, that freedom and that flexibility in eating. When we look at the basal bolus regime with a change in your bolus doses. So the first ratio we are going to look at is called the insulin to carbohydrate ratio. And this is basically the amount of insulin that covers a certain amount of carbohydrate. And we usually start at about a 1 to 10 and adjust depending on how the body responds. So 1 unit of insulin to cover 10 grams of carbohydrate. Okay, so what that means is that if I'm having breakfast, some cereal with milk, and I'm eating 40 grams of carbohydrates, I divide that 40 by 10 to make 4 units of insulin with the bolus so that I can cover those carbohydrates. Okay, that is an insulin to carbohydrate ratio. The second ratio that we are going to look at is your insulin sensitivity factor, ISF. This is how many millimoles per liter the blood glucose will drop for every unit of insulin. For example, if your blood glucose is at 9 and you give yourself 1 unit and it drops down to 6, that means 1 unit of insulin drops you by 3 millimoles per liter. It could be 1 to 2, 1 to 2.5, 1 to 3. Usually we start at about 1 to 3. Okay, so we have the ISF and the insulin to carbohydrate ratio that are working together at every meal time. Okay, so let's go through a basic day. We'll start at night because it's easier, and most people take their basal or long-acting insulin at night. Your doctor has said you need 36 units of that. You inject and you go to sleep. Okay, wake up in the morning, test the blood sugar. It's 9. Okay, great. I know that I have a 1 to 3 ISF, insulin sensitivity factor, so I am going to give myself 1 extra unit of insulin, depending on what my insulin to carb ratio is. I'm about to eat breakfast. It's 40 grams of carbohydrate. I've counted it, and I'm at a 1 to 10 insulin to carbohydrate ratio, so I am going to give myself 4 units of insulin to cover those 40 grams. 4 plus 1, 5 units of rapid-acting insulin. Okay, I inject, and then I wait about 10, 15, 20 minutes, and then I eat my breakfast. Great. Go to school, live a good life. Okay, it's lunchtime. What happens? Test the blood glucose. It's 6. Great, everything's going well. I don't need a correction. I don't need that ISF ratio. I'm about to eat my sandwich. It's a cheese sandwich, 2 slices of bread. It has 30 grams of carbohydrate. That means with my 1 to 10 ratio, I use 3 units of insulin. I inject 3 units of insulin, and I'm good to go. Supper time comes. Check the blood glucose. It is 12. Oh heck, okay, I want to bring it down to 6. My ISF is 1 to 3. So I give myself 2 extra units, okay? I'm quite hungry. I have a nice big supper, 70 grams of carbohydrates. That means with an insulin to carbohydrate ratio of 1 to 7, I take 7 units. 7 plus 2, 9 units of insulin. I inject, and then I wait a little bit. I eat my supper, and great, maybe I watch some TV, do some homework, and then just before bed, I check my blood glucose, just because it's a really good habit to check what your blood glucose is doing just before you go to bed. If it's on the low side, you might want a little snack. If it's on the high side, and you ate your supper more than 2 hours ago, you can give a correction dose. Lots of things that we can do to try and keep the blood glucose in a good range. There are many, many, many things that affect the blood glucose. It's not just insulin and food. It can be affected by stress, where you are on your hormonal cycle. It can be affected by illness. It can be affected by exercise. Different types of exercise do different things to the blood glucose. There is a lot happening, and a lot of things affect your blood glucose. So what I want to say right now is that you probably will never get it perfect, and that is fine. All we do is the very best that we can to try and stay within a normal range, to give the body the best chance of good, healthy, long life. Don't put too much pressure on yourself to be perfect. It is not likely to happen. Great, so those are the basics of the treatment of type 1 diabetes using insulin and a basal bolus regime. If you have any questions or comments, please pop them down below. I'd love to engage with you. Otherwise, I'll see you at the next video.